ជាកម្មវិធីបន្ទាប់នេះខ្ញុំសូមប្រកល់ជូនលោកសាស្ត្រាចារ្យ Michael Grosser ជាប្រធានអាសនៈ លោកជាអនុប្រធានមូលនិធិគន្ធបភាស្វីសនិងជានាយកមន្ទីរពេទ្យកុមារស៊ូរិកដឹកនាំជាមួយលោកសាស្ត្រាចារ្យ Christine Bricker ជាសហប្រធានអាសនៈ លោកជានាយកផ្នែកស្រាវជ្រាវអាហារូបត្ថម្ភនៅមន្ទីរពេទ្យកុមារស៊ូរិក
I would like to hand over to Professor Michael Grosser as chairman. He is the vice president of Kantha Bopha Foundation in Switzerland and medical director of the Children's University Hospital in Zurich, and Professor Christine Bricker as a co-chairman. He is the director Nutrition Research Unit University Children's Hospital in Zurich. Both of them lead plenary session 1, which consists of 5 topics and lasts for 90 minutes. Thank you.
So it's a huge pleasure for me to open this session with my dear colleague and friend, Professor Christoph Berger. It's probably important for you to know that in Switzerland, Professor Berger is the national president of the Commission for Vaccination, and he is one of the most important persons during COVID pandemic, and was extremely often present in newspapers and in TV. So he is in Switzerland the real expert on COVID, and we are pleased to hear his presentation, General Consideration and Actuality of the COVID-19 in Pediatrics in Switzerland. Thank you.
Thank you, dear Chairman, dear organizers of this international symposium. It's really a deep honor for me to talk to you at this international symposium in Siem Reap. So as mentioned, I did a lot for the immunization program in Switzerland, and what I will talk about is not only the immunization, this is the second part of this talk, but you have to acknowledge, to realize that I will have, this is my perspective. My perspective is from Switzerland, and this is why I put this first slide. We do not, this is just one perspective. And COVID was different in different countries. And this is just from the dashboard from the WHO. And what it shows is that not only these waves of SARS corona variants were different in different countries, but also the number of cases and the deaths completely different. And this depends on testing schedule, on the collecting national data, and of course also of the population. I think the age structure of the population in Switzerland is different from the one in Cambodia. We have much more people that are aged over 80 years than you have in Cambodia. And all this has impact on the numbers. And so what I will tell you is the Swiss perspective, and I try to compare to other regions as for example in Cambodia. So this, you know, I make that short. We have the vaccinations have an important role in COVID-19, in this pandemic. And it changed with the start of immunization the population against COVID early in the year 21. And there were different classes of vaccines, and we know a lot about these vaccines, especially of the inactivated vaccines, as you have most used here and in this region. And then we have subunit vaccines, then we have mRNA vaccines, never used in such extended dosages and never produced as in this pandemic, and we collected a lot of experience. And then there are, in addition, the vector-based vaccines. You all know this, and why do I show you that? Because at the end, all these vaccines induce a peptide or a protein that is against spike protein of SARS-CoV-2, and this induces the immune response, which downstream from that step is always the same. So and now I just want to introduce to you to what we did in Switzerland. So the strategy was to diminish the burden of disease, of COVID-19, and to reduce death and severe disease. This is first and highest priority. Second, to maintain the health system so that we have, that we can care for sick people. And third, to reduce the negative effects of the pandemic. That's not only the virus, it's also the measures against the virus. And if you look at this table there, then you can see on the left, it's the number of cases related to age. In the middle, it's the number of hospitalizations and the incidence, and on the right, it's the number of deaths. And if you see that, the red marked fields represent where we have the highest incidence. So you see that the highest incidence is in the young people, but the most severe disease and deaths are among the elderly. So this was the strategy, a risk group approach to protect those first. And this is focused on the elderly. And then here you see the cases on the top right, and then the hospitalizations during the course of the pandemic. And what you can see there, that with the pandemic evolving and the different variants of the virus, from Alpha to Delta to Omicron, you see that, and the immunization. So you see that the number of cases is increasing with Omicron, higher than ever, but because Omicron is different and because the people at risk have been immunized, the number of hospitalizations did not increase so much. And with every new wave, there was a shift to younger age, so that children get involved more and more, and most in Omicron. So this again, in the beginning there was a lockdown, there were restriction measures just to manage the pandemic, to keep these aims. And there was a lockdown, stay at home, closed schools, social distancing, masks everywhere. This was to protect the vulnerables. But what about the children? The children are not vulnerable, as the elderly are, for this virus. But they had there was a solidarity in the whole population with these measures. So, what is the manifestation of SARS coronavirus 2 infection among children? This is in a very early report in the year 20 from the US. And what you can see, that these COVID symptoms in children are non-specific. That's different to adults. And it's so non-specific that it's even difficult to discriminate SARS-CoV-2 positive tested children from other children with an infection. And this is important to know. That has impacts on testing strategies. And then there are even more publications, and then you see that all of you know that these are the clinical manifestations of SARS coronavirus 2 infection among children. Fever and cough is the most frequent manifestation, and so it's just not much different from another viral respiratory tract infection in children. What does this mean? This has an impact, and I'm here as a pediatrician, and I think this is very important, that children are not small adults. It's different, it's not only small. And this is one of these impacts is that we had the transmission was different in the beginning between adults and children. Children get infected, children can transmit, but not as much as the adult did. So, if we know that, and if we know that the disease is mild in childhood, and we have no risk factors for severe disease in the beginning, why do we close school? We should not. And in Switzerland, I'm very proud, we succeeded to have a very short period of closed schools. I will come back to that later. So, what about management and treatment of children with COVID? The most important thing is, if you have a child with a chronic disease, with a comorbidity, the most important thing is that you manage this comorbidity in a very stable manner. If, for example, diabetes, you have to have a very good management with the insulin so that the sugar is very well constant. If you have asthma, if you have congenital heart disease, do not change anything of the manifestation of your just chronic medication. This is the most important to prevent severe COVID. And if you have COVID, there are several discriminations between mild and severe and critical. This is just whether they need oxygen or whether they at the end critically need ventilation, but it's very rare, but there are some children. Indications for hospitalization is the severe respiratory tract infection, or you may have a lower threshold to hospitalize a child that has a comorbidity, and in Switzerland and many other European countries, we hospitalize these very young infants because we do not know if they have fever, whether this is a dangerous infection other than COVID. I'm a little bit provocative to make the difference. So, and if the child is hospitalized, so you just do supportive care. And that's the most important thing you do. There are specific medications, but we do not frequently use that, and it doesn't make the difference. It's only for selected cases. You can give steroids, and you can give antivirals. It's remdesivir at first line, and in very rare cases at all. And I just summarize to you what is known and what is the guideline character of where we are in the antiviral treatment of COVID in children, and it's remdesivir. And if you look at the table, you see that many of the other drugs are not authorized for children younger than 12 years of age. And I can tell you that there is not more than one hand of children in the Children's Hospital in Zurich that got remdesivir in Switzerland. We didn't give that, and I think we managed them well. And then there is another thing. There are different medications that have been used that are not recommended. You can read that at the bottom line. This does not help. You do not need to do that. Second thing is steroids. And I just indicate here on this slide what is the different steroids you can use for this. It's a short time steroid treatment with different steroids. And about monoclonal antibodies, just 2 remarks. First, this is only very rarely used in children if you have very highly immunocompromised hosts, maybe transplant patients or something like that. Then you can use this. And this is evaluated only for older children and never for young children. And as often in pediatrics, we do adapt from adult data without having controlled data on children. And this is always a risk, and we should not do too much experience there, otherwise you do harm and not help. And so, this is the first remark, and the second one is with the monoclonal antibodies. It is important that you know what antibody this is. If this is related to Wuhan or alpha strains and you have Omicron, it may be that these antibodies do not longer fit, and then they do not help. This is just to consider. Next, and this is an important slide. This is these PIMS or MISC multi-system inflammatory syndrome in children. This is important that you know, that pediatricians know that that exists. Because the pediatricians have to recognize this severe manifestation, very rare, as you see on the top. You have to diagnose and you have to send those children immediately to the hospital. They need hospital care, intensive unit care, and then prognosis is good. If you miss it, they probably, part of them will die. So and then you have 3 presentations: is a systemic inflammation with fever that can present as a Kawasaki-like disease, or as a sepsis-like disease, or as an appendicitis-like disease. Send them to the hospital, it's very rare, and they can treat. So the next thing is what we learned is this severe manifestation of PIMS or MIS-C is rare and is the primary infection, the primary contact with COVID. So if the children have been immunized, this manifestation will be much less frequent than before, even rarer. And these are data, just 2 studies, showing clearly what is the impact on vaccination on the prevention of PIMS. The second thing with PIMS is that it's dependent on the viral variant that is just spreading in your population. And among Delta-infected children, this is more frequent than in Delta-infected children after vaccination, and it's even more frequent than in Omicron-infected children. That's what's shown on this graph. This is what I announced before. So this is an UNESCO data, very impressive. Go there, look at that. It's interactive, you can choose several countries, several regions, whatever you want. And what you can see is how long schools have been closed. And I just made some examples on the right. And you see huge differences. And what is the message here? It's not the virus that's most dangerous for children. Only for a very few of them, but for all the children, what really has impact, negative impact, are the restrictive measures against COVID for the population, not for the children. And so and for the health of children, it is very important that you have everyday structures that are as normal as possible. And so you should limit school closures as fast as possible, and you see the huge differences. And there are still sequelae of these measures. Second sequelae of these measures, not the virus, but the restrictions for adolescents. You can see here. This is the global prevalence of depressive and anxiety symptoms in children and adolescents after the first year of the COVID pandemic. So this means that 1 in 4, that's a very high number, youth experience depressive symptoms, and 1 in 5 anxiety symptoms. And this is higher than ever before. And this is just what I want to show you, what is different in children. And the virus is not as dangerous as the measures that are taken to protect from the virus. And now we have the question, what is the role of vaccination in this situation? And there I show here 2 different indications. One is the direct protection of children against rare severe disease. And the second is the indirect protection. Should we use the vaccine to lower the restriction measures? Do you immunize children not only to protect against the virus, but that we can lower the measures? This is a huge discussion, and I think this is very difficult, and we should very much stick to the evidence there. So it's important, and I will show you data on the vaccine in the next slides. This is important. We have this vaccine, and we should and have to use that. But we have to be clear what's the aim of vaccination in this situation. And then the second, I just talked about this, is do we need vaccination to make the everyday life of children more free? Maybe we have other measures, or we can immunize the rest of the population and reduce the measures by that. So this is just if you want to look at an international guideline. It's very international, this guideline, very recently published. And it's just a summary of the vaccines that are available and recommended for children as young as 3 to 5 years. First, there is no data on immunization, almost no data on immunization of children younger than 3 years. And the question is whether they really need to get the vaccine. And what you see here is the different vaccines that I announced in the second slide in the very beginning. You can see what is the data that is available, really efficacy and immunogenicity data for children. And I will focus on that in the next slide. The most available data is from the mRNA vaccine from Pfizer. But you can also use the other ones, they protect as well. So now, we had the change when we introduced the vaccines for children, the vaccines against COVID for children in Switzerland. This was at the end of the year 21. This was at the same time when the variant switched from Delta to Omicron. And we realized soon that Omicron is induces much more infections, is much more contagious, but has much severe manifestations. And severe disease is very, very rare, even rarer in children than the Delta. This is the first point. The second point is, here is just an effectiveness study of a 2-dose mRNA Pfizer vaccine data, and what you can see, these children have been tested regularly, irrespective of symptoms. And what they found is that at least half of the children were asymptomatic when they were SARS-CoV-2 PCR positive. So this is important to know. It's just fact. And then what is the effectiveness of the vaccine? You see at the bottom in blue, or you see in the table as well. This reduces the infection. That's not severe disease. It's infection among children about 30%. So you immunize 3 and 1 does not get infected. Or in the adolescents, it's higher, it's about 60%. Third, what we learned, and this is a very nice study from Italy in the spring this year, that the effectiveness is higher in older children than in younger. And the second and the much more important result of this study is that this protection is very limited in time. You see on the graph that you have an effectiveness of about 40% that goes down to 30% already after 1 month. And after more than 2 months is just 20%. You can give this vaccine, it's safe and it helps, but the duration is very limited. You have just to be transparent and not surprised if they get an infection after 3 months. Next, also the immune system of a child is not just smaller than, but equal, but than of an adult. It's completely different. And so is the immune response against infection. This is also a very nice recent study that shows that at younger age, with infection, you get a very rapid neutralizing antibody titer, And this titer will last longer in younger children than in older children and adults. So this immunity is very good. The fifth point. This is Swiss data on prevalence of antibody prevalence in the population against SARS-CoV-2. So in the beginning of the pandemic you have a low seroprevalence in the population, and at the end you have a high one. And this increases faster in the older people because they get vaccinated as the first group. And in June 22 in Switzerland, almost 97% of the Swiss population have antibodies because they have been immunized and or infected, mostly both. So if we know that, then every infection is a reinfection or a breakthrough infection after vaccination. Every vaccine is a booster. If we know that severe infections are much rarer than in the beginning because we have some kind of pre-existing immunity or immunological memory. And this is just at the second last slide to show you just some principal thoughts about immunity and risk of infection or reinfection and the potential of the vaccines. In this graph you see the different levels of immunity. To be protected, the immunity level has to be protected against infection. The immunity level has to be higher than to be protected against severe infections. This is the higher and the lower horizontal line. This is the first point. And if you give 2 doses of vaccine, you have a peak. You have a decrease of the immunity, and then you can boost, and you have again an increase. But the levels you reach in a young, healthy person is higher with the same vaccine than in an older or comorbid person. So if you have this in mind, it makes clear what we can reach with immunizations. We have only, and this is exactly what we have with Omicron, if you are boosted, you are protected longer time against severe infection and short time or not at all against symptomatic non-severe infection. And these vaccines do not protect from transmission. So this is very important. Otherwise, we are not transparent and do not give the right information to the population. If you are boosted, it is well possible that you can get an infection, but very unlikely that you get a severe one. So that's the message, and we do immunize now, not to change the circulation of the virus. We cannot achieve that with Omicron, but to give an individual protection against severe disease. And this is what I just said is even true for the new Omicron variants BQ1 or the XXB. So now the summary of what I tried to transform as an information and my perspective to you. So COVID has caused a pandemic, and it is most severe among the elderly. In children, it's a viral infection that is rarely severe. We have this very special manifestation of PIMS, MISC, that you have to know to send these children in hospital. It's even rarer now. And this is really my point for the health of children and adolescents. We have to consider if we take measures, restriction measures in the population, what happens to children. And I hope that this will be considered for in all these future pandemic plans. Maybe the next virus is different, and maybe severe for children and not for the adults, but you have to consider along the data you have. And then vaccination in children is safe and effective, but the effectiveness is limited and short-lived. And with increasing circulation of the virus, the population has antibodies, and the possibility to get severe infection will decrease and decrease. Thank you.
Thank you very much, Professor Berger, for this impressive talk. Are there any questions from the audience? Maybe I start with a question. So what do you expect for the next 1-2 years? Do you consider COVID-19 right now as a normal viral infection, or do you consider a risk for further problems and restrictions?
I mean, this is a difficult question because it depends on the evolution of the virus and the emergence of dangerous variants. But this is already evolved, and the question is how will it evolve in the future? I don't know that. If we have variants that are some related to the Omicron that we have now, then I do not expect a variant that has to induce this kind of restrictive measures again, and I hope this will be true. And second, I think yes, we will live with this virus, and we will have to protect the vulnerable people that are not well protected, and that you can boost the immunity of those you can boost with a booster, and this is the elderly and those with comorbidities. But I think this is somewhat similar like for flu. But this is just the hypothesis how we see that in the moment.
Maybe another question. You showed impressive. Afterwards, we have a question from the audience. You showed impressive differences in duration of school closure throughout Europe. So, what was the difference in Switzerland compared to other countries for this? What do you think?
I think that we realized in Switzerland very early that this COVID is not so dangerous for children. And what we did in the beginning is we separated the children from the elderly, that they do not transmit. And we realized that we do not have school outbreaks. And if you do not have that, you can act. And I think this was very good. You saw the difference. It's a very big difference between, for example, Switzerland and Germany. This is another political system, and I think we really had a good contact with the government to motivate them to reopen schools. And I think in not as much developed countries as Switzerland, the effects of school closures are even more important, because then they stay at home, they have no meal at noon and things like that. I really hope that this will change, and I'm very happy that we succeeded to change that in Switzerland very fast.
In addition, I think it was very important to have pediatricians in important positions, because pediatricians know better about children, right? So we have a question from the audience.
Yeah.
I'm Dr. Beat. I'm not a pediatrician, but I'm a surgeon. I have one question concerning the vaccination. In your idea, do you think that now the booster, we still need a booster for the children that already vaccinated? is booster really useful, and we need to do a booster for children or not?
Thank you. Yeah, the question is, do we need a booster for children? Huh? Yeah. Now, I think it is important to know that we have the vaccine, that the vaccine is safe and has some effectiveness. In my perspective, and this is again the Swiss perspective, it's important that you protect the vulnerable children. Those with a comorbidity, there you just need any kind of viral infection and they have to go to the hospital because they are not stable anymore. That's not only COVID specific, it's a general. It could even be RSV or maybe flu. This is the one thing. And the second thing, if you think you have more reserves, you have more capacity to keep the schools open, then do it, because the schools have to be open.
And other questions from the audience?
Good morning, Professor. I'm a pediatric cardiologist here, and I have a question. COVID-19 can be manifested as a Kawasaki disease. So should we treat as a Kawasaki or we treat as COVID-19?
I mean, if you say it's COVID-19, what makes the difference?
Yes, but there is a picture like a Kawasaki disease. So we treat as a Kawasaki or we treat as COVID-19?
I mean, I don't know, how do you treat Kawasaki? Probably either with steroids and or with immunoglobulins.
Yes,
and
exactly.
it's very close to what you do with COVID. But I think if you, in general, in the literature, in the reported cases, the Kawasaki children generally are younger as those with PIMS or MISC. So this is some kind of difference. If you are not sure, I think, yes, you have to treat, and it's a related treatment because also the pathogenesis is probably maybe somewhat similar. But here I'm not the expert. I think even in a child that has got a vaccine against COVID, I would rather think about Kawasaki.
Thank you.
Are there additional questions?
I have another question concerning all the type of the vaccination of the vaccine that we have now. So which one is the best? Suitable for children? In your idea, which one is the best for children?
What is the best for children? I tried to go deeper than what I showed in this guideline. I know the data that are available for the Pfizer vaccine for children. And this is, I think, the best data we have. It's even better it's less than for the Moderna. And I did not find really good studies anyway for Sinovac and Sinopharm for immunizing children. If you have a very good study, I would be happy if you could send that to me. It's just I cannot answer your question because do we have specific data? If we have not, then go to the vaccine where you have the best data.
Additional questions? Otherwise, we thank you very much, Professor Berger, and I hand over the microphone to Professor Brecker. Thank you.